Now, what is going to be different about celiac disease and chronic pancreatitis is that celiac disease and chronic pancreatitis, the two unique things about celiac disease and chronic pancreatitis is that celiac disease and chronic pancreatitis are both going to be the only ones presenting with steatorrhea, fat malabsorption. Steat, a $5 word for fat. Rhea means flow of fat from your ass there. Steatorrhea, fat-o-rhea, diarrhea with fat. Rhinorrhea, diarrhea of your nose. Steatorrhea, diarrhea of fat. And that is why the stools here are going to be floating, flying, oily, greasy. It's very significant weight loss. And of all the forms of diarrhea, the one that is going to be most likely to have weight loss is going to be the ones with a fat malabsorption. The ones that have the most weight loss are going to be the ones with a fat malabsorption because fat has the highest caloric content. Floating, flying, oily, greasy, frothy, feculent. Now, you may be looking for me to saying foul smelling. Now, it is foul smelling because it's like fermented fat in your rectum. Like a wine tasting. What is this special thing, this bouquet of this fermented fat? But the foul smelling thing I never quite understood because, first of all, you have to ask people, hey, listen, how does your stool smell? Does anybody ever say, oh, mine smells like flowers? Everybody smells foul. So maybe this is supposed to be especially bad. But the point of it is, all stool smells bad. None of it smells like roses. But this is especially bad because the oily, greasy fat is fermenting in your butt. All right. I got the poetic moment. Get on with it. Well, that's both of them. That is both of them. And as a matter of fact, that not only is both of them, that could be tropical sprue as well. There's celiac sprue and there's tropical sprue as well. Now, personally, if you had to have one, would you rather have tropical sprue or celiac sprue, gluten-sensitive enteropathy? Most people would rather have the tropical sprue because tropical sprue is diagnosed by a biopsy showing microorganisms and diagnosed by a biopsy showing microorganisms, and tropical sprue can be treated with Bactrim or doxycycline. Bactrim or doxycycline for 6 months, and you are treated. And it's cured. Nothing can cure your gluten-sensitive enteropathy. You have to avoid wheat products for the rest of your life. No more rolls. No more bagels. No more bread? Gee whiz. Gluten-free cake? That's sort of a drag. Oh my goodness. It's a very bready society. Okay? What do you do when you can't have bread for the rest of your life? Tropical sprue, by comparison, is to see the same thing as all these, except the person's been visiting a night in the tropics. And they got infected with a bug that blocked the lacteals, and they get a biopsy, and they get treated with antibiotics for a couple of months, and it goes away. Well, what's the difference on these in presentation? Well, probably chronic pancreatitis will give you a history of pancreatitis. That's one thing about chronic pancreatitis, gives you a history of pancreatitis. But the other thing is they both present with a fat malabsorption, all of them do, so you can't truly distinguish them by just the history of fat malabsorption. You can't truly distinguish between these just by the history. So therefore, the only way to truly distinguish between these, in the past, we did D-xylose testing to distinguish whether the bowel wall was normal or the bowel wall was abnormal. D-xylose is an oral labeled substance which should go in you orally and come right out in your urine. So oral labeled D-xylose should come right out in your urine if your bowel wall is normal. However, antibodies against gliadin, anti-gliadin antibodies, which is a $5 word for wheat, or anti-endomysial antibodies, which is a $5 word for your villus structure, and anti-transglutaminase. In other words, we have largely replaced the need for D-xylose testing with much more specific diagnostic testing. Anti-gliadin, I'm allergic to wheat. Anti-endomysium, I'm allergic to wheat and my villus lining. I'm allergic to my bowel wall. D-xylose testing, oral label D-xylose and checking the urine, simply told you my bowel wall is normal, it goes into the urine. My bowel wall is abnormal, it doesn't go into the urine. But anti-gliadin and anti-endomysial antibodies have far greater specificity. It's like haptens for red cell disease. A hapten was a half an antigen that when you took it, like penicillins or quinidine, or alpha-methyl-dopa, that when you took the quinidine or the penicillin or the alpha-methyl-dopa, part of that protein stuck to the surface of the red cell, and it made an antibody that could attack both that antigen on the red cell as well as the red cell itself. And therefore, you would end up having hemolysis on the basis of an antibody response against your red cells, drug-induced hemolysis. But only when you had this foreign antigen, only with this antigen, no hemolysis. The same concept for gluten-sensitive enteropathy. No antigen, no bowel inflammation. No antigen, no bowel inflammation. The point of celiac disease and chronic pancreatitis is that here you're demonstrating that you have what's essentially like a hapten mechanism. Without the wheat, you don't make the antibodies. With the wheat, your body is allergic to both your bowel wall and the wheat. Now, unlike lactose intolerance, if you have lactose intolerance and you stop drinking milk and milk products for 1 day, your diarrhea will go away. 1 day. No milk, no diarrhea by tomorrow. Cure it by tomorrow. However, celiac disease is different. You stop the wheat, you still have circulating antibodies flying around for weeks. You stop the wheat, it takes weeks for the diarrhea to go away because the antibodies are still circulating around. Now, which of these is the single most accurate test? These or D-xylose, the single most accurate is a bowel biopsy. The reason that it's the most accurate is because it shows the flattening of the villi. And even if you know that you have celiac disease, even if you're 100% sure that you have celiac disease, you still need to do the bowel wall biopsy. Why? Because the bowel wall biopsy excludes lymphoma. This is an autoimmune disease where sometimes those lymphocytes develop a schizophrenic disorder known as cancer. The immune system, they don't know when to die, they don't go to work, they become little psychotic lymphocytes, lymphoma. Your immune system has now developed a psychosis, and that's what cancer is. It's a psychotic cell. They don't obey reality, they don't know when to die, and they start attacking everyone around them. Cancer is basically psychosis and schizophrenia at the cellular level. The biopsy is the way to exclude the bowel wall lymphoma. D-xylose, normal bowel wall, abnormal bowel wall. That's very nonspecific. However, celiac disease, I'm allergic to my bowel wall, anti-gliadin, anti-endomysial, anti-transglutaminase, anti-gliadin, anti-endomysial, anti-transglutaminase. Hey, doc, it hurts when I do that. Don't do that. Hey, doc, it hurts when I eat wheat or rye or oats or barley, wheat or rye or oats or barley. Well, I see a lot of rice cakes in your future. Rice cakes and gluten-free wheat. I see a lot of rice cakes. I see a lot of steaks. I see a lot of shish kebabs. In your future, can now have an unlimited red meat diet. It's totally safe. Stop the wheat. Just remove the wheat from the body. Chronic pancreatitis. Chronic pancreatitis can be diagnosed with X-ray, but the problem is only 50% of patients show the calcifications. CT scan, but CT scan also will miss a lot of cases. Chronic pancreatitis is most commonly diagnosed by a history of repeated episodes of pancreatitis, clearly most commonly from alcohol or gallstones, progressing to steatorrhea, weight loss, floating, flying, oily, greasy, disgusting, stoolish poo-poo. The CT scan and the X-ray show calcifications. Now, what that means is that X-ray and CT scan for calcifications, what happens and how do you make a diagnosis if those calcifications are not there? And the answer is that what you have to do is that you have to sometimes infer it from the history of recurrent pancreatitis with the fat malabsorption by seeing the evidence of calcifications. The problem is that amylase and lipase won't help you, because by the time you develop your chronic pancreatitis, your amylase and lipase are normal. By the time you develop your chronic pancreatitis, your amylase and lipase are normal. So therefore, when your amylase and lipase are normal, it's because the pancreas is all burnt out. So your amylase and your lipase are normal. And by the time your amylase and lipase are normal, it's because if your pancreas has all been fried up and juiced and juiced and juiced, there's no amylase and lipase left in it. The pancreas is like a big fruit. And when this gets inflamed, it juices out some amylase and lipase. And it juices it out. And eventually, there's no juice left in it. There's no amylase and lipase left inside that pancreas to allow it to make any more of those enzymes. It's all juiced out. Eventually, it does calcify. And the diagnosis is presumptive most of the time. Now, not that you will hardly do it, but if the question says, which of the following is the single most accurate test, it is a secretin stimulation. Now, secretin, the first hormone ever described, secretin, I think it makes you secrete in? You secrete inside you. Secret in. Secretin is a hormone that makes your pancreas release its contents of bicarbonate. Acid normally goes into the duodenum. The duodenal cells release secretin. And secretin is supposed to make the pancreas eject a load of bicarbonate to neutralize that acid. The secretin stimulation test is the single most accurate test for chronic pancreatitis. I put a catheter in my nose, I inject the secretin, and I wait to see if my pancreas excretes a big load of bicarbonate. And that's the secretin stimulation test. Whether or not a big load of bicarbonate has been released in response to that dose of secretin into the bloodstream. And that's how you make the diagnosis. Secretin stimulation test. Now, the next thing is how do you treat it? And chronic pancreatitis, every enzyme that you're deficient in can be replaced orally. So chronic pancreatitis, when you're not making amylase, you can take amylase by pill. When you're not making lipase, you can take lipase by pill. When you're not making trypsinogen, you can take trypsinogen by pill. So amylase, lipase, and trypsin can all be simply replaced by a pill. Look, I like my pancreas. I'm sure you like your pancreas too. But if you're missing your pancreas, don't worry. We got a pancreas and a pill. Come on down to Organs R Us. We got any kind of organ you want down here. Come on down to Organs R Us. You need a pancreas? We got a pancreas and a pill. Don't worry about that. You need a stomach? We got a stomach in a box. You don't need that acid anyway. Any organ you want, we can probably sell you one that comes in a box. It may not be as satisfying as the original, but it'll keep you alive. Therefore, anytime you want, you can get a big bucket of pancreatic enzymes. Amylase, lipase, trypsin, all in a pill. Come on down here now. Calcifications with a history of recurrent alcoholic pancreatitis is 3/4 of the way to your diagnosis. Secretin stimulation is if the diagnosis is in question. D-xylose testing is largely archaeologic. The string test, putting a string into your duodenum to see if you can catch Giardia, is archaeologic. It's the wrong answer. The Bernstein test, dripping acid into your esophagus to see if you howl in pain, is an archaeologic test for people who have reflux disease. And the other people here, you're looking for a 72-hour fecal fat collection? 72-hour fecal fat has been replaced by just doing a Sudan black test. And the Sudan black test tells you on a single test if you have all that fat in your stool. The Sudan black test tells you on a single test if you have that fat in your stool. 72 hours of fecal fat, get out the paint buckets and catch 3 days of poo-poo. If somebody tells you to do a 72-hour fecal fat, say, why can't I do a single test of a Sudan black stain testing for fat malabsorption now? That should be enough. The other thing is, every time that you have a fat malabsorption, you have decreased levels of vitamin D, leading you to have low calcium. You have decreased levels of vitamin A, a fat-soluble vitamin. You have decreased levels of vitamin K. And vitamin K ends up leading you to have an elevated prothrombin time, and you bleed. Now, one of the ways that you're going to distinguish fat malabsorptions from the other forms of malabsorption is that fat malabsorptions have diminishment of calcium, vitamin A, D, E, and K, ADEK, vitamin A, D, E, and K. You're going to get hypocalcemia. You might bleed from the low vitamin K and elevated prothrombin time. Now, the difference between this and celiac disease is that in celiac disease, you get all that and you get a decreased iron level. Because you see, in chronic pancreatitis, you don't need pancreatic enzymes to absorb iron and folate. In chronic pancreatitis, you just get this part because you're not absorbing the fat absorbable enzymes. However, celiac disease is a bowel wall problem. So you're not absorbing iron, B12, or folic acid either. You're malabsorbing all kinds of things when the bowel wall is abnormal. In chronic pancreatitis, we don't need pancreatic enzymes to absorb folate and iron. So in chronic pancreatitis, these will be normal. But they will be down in celiac because this is a bowel wall problem. Chronic pancreatitis is an enzymatic deficiency. So you're only missing the ones where you need the lipase to absorb. You don't need lipase to absorb these. This is the bowel wall problem. 72-hour fecal fat replaced by Sudan black staining. Malabsorption of the fat absorbable enzyme. If somebody tells you to take and collect 72 hours of fecal fat, you say, no, I'm only going to take one spot. I'll take one little bit of your stool and that's it. And that's all I need to know what you're really like. And somebody says, no, you have to take it for 3 days. You say, no, I've taken your stool once, but I'm not taking any more than just that once. And that's why 72-hour fecal fat is no longer necessary. Bernstein testing, dripping acid in my esophagus, no longer necessary. String test, putting a string into my duodenum to test for Giardia, no longer necessary. We have stool for Giardia antigen. When I'm looking at any form of diarrhea, the first thing I do is I have to exclude an infection first. In order to exclude an infection first, you look and see whether there's blood or white cells. Fecal leukocytes and blood tells you the same thing, invasive diarrhea. And you exclude infections by doing stool for white cells, stool for culture, stool for ovum parasite exams, stool for Giardia antigen. Next thing is, once you've excluded infection, then we will see, is there blood and is there fever? Can't be lactose intolerance. Lactose intolerance is easy. Take rid of the milk product, get rid of the milk products, lactose intolerance diarrhea goes away. Carcinoid is unique. You've seen we've given you some unique qualities so that on each of them when it says, which of the following is the most likely diagnosis? You can answer because you say only carcinoid is intermittent with flushing and wheezing. Only carcinoid gives you tricuspid insufficiency and pulmonic stenosis. Only the fat malabsorptions will give you diminished vitamin A, D, E, and K. Then you do the blood testing for celiac disease and look for calcifications for chronic pancreatitis. Celiac disease treatment is easy. Knock the weed out of your diet. Chronic pancreatitis treatment is easy too, which is to say replace the enzymes with oral replacement, and it will get better. And that's all we have to say about diarrhea.